Good afternoon and welcome back. I'm Lauren Hardin, Vice Chair of PTAC. I'm pleased to welcome our second listening session on assessing best practices in care delivery for population-based total cost of care models. We've invited 4 outside experts to give short presentations on their vision for population-based total cost of care models based on their experience. You can find their full biographies on the ASPE PTAC website. Their slides will be posted there as well. After all 4 presentations, our committee members will have plenty of time to ask questions. Presenting first, we're honored to have Dr. David Grossman, who is the Interim Senior Vice President of Social and Community Health at Kaiser Permanente. Please begin, David.
Great, thanks so much, and thank you for this opportunity to present Kaiser Permanente's total cost of care model today. I'm a pediatrician and I lead social and community health, where our team oversees the integration of social health assessment and interventions so that we can provide socially informed care to our members. And this is a cornerstone to KP's work on health equity. Next slide, please. For those that are not familiar with Kaiser Permanente, really a quick primer. We are the largest private nonprofit integrated care system in the United States with over 12.5 million members, about 23,000 employed physicians, and over 200,000 employees in addition. And our care span includes the full continuum. It also includes a set of 8 non-proprietary health services research centers. Our plan, and as I'll describe in the following slides, our health plan and our care delivery are deeply integrated and intertwined, and sometimes are difficult to set separately. Next slide, please. So this map. Next slide, thanks. This map shows the distribution of our member population in the U.S. And as you can see, the significant majority of our members reside in California. In many of them, we are largely concentrated in metropolitan areas or large population centers, and our penetration generally runs in any community from about 20 to 40% of the insured population. Next slide. So, although Kaiser Permanente is actually a brand name, I think for the purposes of the discussion, it's important to tease out what actually is Kaiser Permanente. It's actually a set of discretely separate chartered, mostly nonprofit organizations that are all focused on serving our enrolled members. The Kaiser Foundation Health Plan at the top there provides the main functions of a health plan and then serves as the distribution source for global payments to the other organizations in the group. The health plan manages its hospitals through a separate nonprofit called Kaiser Foundation Hospitals, through a series of hospital service agreements. And those services are provided either in Kaiser Permanente facilities or as needed in contracted facilities. In California, it's mostly owned. Outside of California, it can be either owned or contracted. Some regions like Washington State and Georgia, for example, do not have Kaiser Foundation Hospital-owned hospitals. Care is provided in contracted facilities. Kaiser Permanente, but the care is actually provided by the KP providers. So then the health plan also has medical service agreements with 8 separate Permanente medical groups, all self-governed, and 1 for each region. California has 2 regions. The medical groups are mostly shareholder-owned, but some are now moving towards a public benefit model, or some as aware of something called a B Corp organization that serves community interests. Each Permanente medical group has a medical service agreement with its regional health plan subsidiary that provides mutual exclusivity and gives the medical group control over things like clinical guidelines, policies, network composition, and also appeals process. So next slide, thanks. So Kaiser Permanente is distinguished not only by its integration of care, finance, and delivery, but also the integration of the components of care delivery. So we provide the full constellation of care in most regions. The model is also, importantly, is primary care centric. And the entire system is linked through an electronic record, which allows providers, regardless of where you're at in these wheel, you can see all aspects of care delivered, including all aspects of care coordination and case management. And now both mental health and social health are fully integrated into that wheel and into the system. Next slide. So the KP's global budgeting process allows a lot of flexibility in how care is delivered. The constraints of what we perceive to be an arcane fee-for-service system do not generally exist. So specialty care can often be delivered through teleconsults to primary care without any kind of billing process or a need for worry about having to see the patient in person in order to satisfy billing requirements. In our system state, we're throughout our system, and I practiced most of my career here in Washington State. We've been, for example, we were really able to adapt to COVID, saw our telehealth encounters rocket to about 75% with virtual encounters without any concerns about revenue loss from the conversion. And it allowed us to be much more flexible, I think, than many of our competitors. Kaiser Permanente was one of the earliest adopters of the electronic health record, and that investment was absolutely critical to our success in becoming tightly integrated and also enabled much more patient engagement and becoming patient-centered through the earliest versions of the patient portals that were offered by Epic. The Care Everywhere program, which we use, also an Epic product, has been also critical to our ability to offer seamless care across state lines, regardless if our members move temporarily or permanently. And so this has obviously an impact on reducing redundant care or redo of previously done services because all those past services are easily visible. I think finally another major difference in the experience of our medical groups is that they spend far less time having to adapt practices for different payers. So the coverage policies at Kaiser Permanente align fully with medical group practice guidelines that are developed by the medical groups, and that many of these referrals for services are auto-approved based on the Permanente affiliation, in essence, gold carding. And for patients, I think it's a really distinctly different experience as they're not caught in the middle between providers and plans, fighting over coverage and payment. Next slide, please. So the medical groups are actually paid a global fee that's based on a capitation formula, and they in turn pay the physicians and the other providers on a salary basis. There's a negligible fee-for-service billing inside our system. We have to do it generally more for external requirements, and as I'll talk about in a second, for some other special purchasers. But the medical groups can earn extra incentives, both as a group, but also reward individuals based on quality and experience performance targets that are set through a process between the health plan and the medical groups called Memorandum of Understanding. So those members may or may not pay an incentive depending on performance. It's generally driven entirely on strategic initiatives and quality. The source of the revenue to drive our whole system is obviously largely premium payments from purchasers, but also includes substantial patient cost share revenues. There's very little fee for service in our system, but for those employers that are self-funded or risk-based, the model is driven by fee for service payment plus a global capitation fee that'll cover much of the non-billable integrated services like case management, care coordination that are vital to our success of our model. Next slide, please. So our latest integration experiences with bringing social health into the mainstream of medical care. And as a nonprofit, we do have a long legacy of serving not only our members, but also invested in the health of the communities in which our members reside, recognize the importance of public health in the environment and the social environment. So KP provides about $3.6 billion in community benefit that are a combination of traditional charity care, but also an extensive grant and community investment portfolio that focuses on a set of key areas that are mostly commonly uncovered through our community health needs assessment process, which we do across the country. We also recognize the importance of doing social health needs assessments at the member level. and we're now making that visible at the point of care and in the electronic record for purposes of care coordination and care planning, as well as socially informed care. Next slide, please. So this next box represents sort of the model that we are using in social, and we are still in the process of this. We're still, I would say, in the relatively earlier phases of this journey, where we are set up to identify social health needs of our members using standard tools, and then through that process, connecting our members to resources in the community. And those can be through a variety of pathways, which I'll describe in a second. And then enabling and supporting a follow-up with those members, particularly those that have complex social needs or a mix of complex and social and clinical needs, and ensuring that they get the appropriate follow-up as part of their overall care planning. This in turn allows us to monitor the use of the community-based services and amass data and understand the performance of our community partners and their ability to help informs our local investments in those community-based organizations, much in the way we would be supporting a provider network. So next slide, please. This is my final slide. And in this, as you can see here, what we're doing is the screening process is through a variety of pathways, which include at the site of care, using standard quick screening, which can be done either through the provider, say, medical assistant, or through digital self-service tools, or through actually even outreach to a call center that we staff for purposes for people who desire to actually go direct through that medium. We've also listed on our web ability for social services locator platforms that's available to the public so they can see what kind of resources are available in their zip code. We have set up what we call a Thrive Local platform that is powered by Unite Us, that provides electronic communications and connections with community-based organizations in our communities. We have over 5,000 community-based organizations that are connected to the network. And when a provider sends a resource referral, it's delivered electronically, just as it would be in our system, to a specialist. And then we can monitor to make sure it was accepted, that the services were received, and then the feedback is actually received back into the electronic health record. And the areas that we're focused on in these areas, we're putting an emphasis early on in food resources, on housing resources, social isolation, and financial resources. We also are using our ability to use artificial intelligence as well as algorithmic logic to identify members that are likely in need of services, even without screening them, and reaching out to them and offering them services like food assistance. And recently, we reached out to about 4.2 million of our members to enroll them in SNAP. And we were successfully able to enroll probably about 80,000 took advantage of that opportunity and successfully completed an enrollment application into SNAP through that outreach. So those are some examples of how this works. And of course, this all needs to be integrated and very closely integrated into our care delivery system, into our health plan. And as we're finding more and more purchasers are interested in understanding how they can play a role in this effort as well. So with that, I'll conclude and turn it over back to the moderator. Thank you.
Thank you so much, Dr. Grossman. That was very interesting. I'm sure committee members will have many questions for you. They're holding those until after all four presenters have completed. Next, we have Dr. Ali Khan, who is Chief Medical Officer at Oak Street Health. Please go ahead.
Thank you so much for having us, and thank you to the committee for this opportunity, and specifically to Dr. Chinny Perullo for making this possible. We're thrilled to be here today to really dig into, our findings from the wild, right? What's making this work for us, both from a value-based care perspective and a health equity perspective in the real world, and exactly what we're doing. So we'll try to dig into a little bit of context, but really focus very similarly to where Dr. Grossman was around how that integration of information and where details and follow through really matter. So next slide, please. So, from a context setting perspective, none of this is obviously surprising to this committee, but important to recognize we know the challenges before us in American healthcare. We are expensive. We don't necessarily get the value or the output that we hope for from a quality perspective in terms of what we spend. And all too often, particularly for seniors and older adults, negative experiences, chronic disease burden, and cost concentration are all forcing those seniors to make choices every day, as my patients do on the west side of Chicago, between whether to pay for a medication or whether to pay for an electric bill, and how that impacts their overall quality of life and their activation as a whole, right? 96% of Medicare spend obviously relates to chronic disease, and we see this all the time in the hospitals where I work and in the primary care setting where myself and many of my colleagues at Oak Street work. And thinking about how we address this in a multifaceted model is really the core focus for us. Next slide, please. Of course, we also know that for many communities, these problems are even more concentrated. I happen to work in this map of Chicago in the darkest quadrant on the west side, sort of to the left of your screen, in a community called East Garfield Park, which is only separated from downtown in the Loop, that white center in the middle of the map, by 3 miles and about 6 train stops, but about 18 years in terms of life expectancy, which is not surprising when we see the overlap between social vulnerability, as measured by the CDC, health risk factors, and race, and what that does in terms of how social risk factors drive considerably worse outcomes, as was underscored during the COVID-19 pandemic. Next slide, please. We see those same challenges through good data from RAND and CMS when we look at some of the process measures that many of us know and love. So when we look at racial and ethnic disparities, consistently, whether from in either gender, we see notable discrepancies in screening, in treatment, and in prevention across racial and ethnic categories. The challenge of the work ahead of us becomes quite considerable when we think not only about raising the bar in terms of elevating the quality and the consistency of care delivered for this segment of the population, but also how we reduce inequity within that work at a very thoughtful and intentional level. Next slide, please. That really is the basis for us at Oak Street Health. We are a national network of primary care centers for Medicare eligible patients. We operate 140 plus centers today over 20 states, soon to be 21 as we head to Colorado in a few weeks, taking care today of about 115,000 members at full risk with us, either Medicare Advantage, Medicare, Medicaid dual eligible programs, or direct contracting today, and about 150,000 members overall, including traditional Medicare fee-for-service beneficiaries. Next slide, please. Which, as you can see, spans much of urban and working class communities, suburban and immigrant communities across 20 states, including much of the Rust Belt, Southeast, the Southwest, and increasingly into more atypical urban settings. We are not in Southern California, we are not in South Florida, but we have attempted to make this work in communities like Chicago, Philadelphia, Cleveland, Memphis, Jackson, Mississippi, Dallas, Fort Worth, and Albuquerque, New Mexico. Next slide, please. And the reason for this kind of motive in the 10 years since we were founded is really because of the people that we serve. 42% of whom are dually eligible for Medicare and Medicaid. 86% have at least one chronic condition. Most of whom come to us on their first visit with 7 or more medications. And I can tell you, as someone who every week, including tomorrow, starts every visit with pill counts and bottle checks, that far too often our patients are coming to us on 7, 8, 9, 10, 11 medications, but they're wondering why they're passing out every 3 days. And what they don't see is that they've got three prescriptions written by 3 different people, all for the same antihypertensive or lisinopril at the same dosing, and that they're dutifully taking each one. And so yet their blood pressure is in the systolics of the 90s, which is quite low, and they're wondering why this is happening to them. Or they ask, I've been getting my medication and from a mail order pharmacy, and I've got it all with me. And they bring enormous bottles dating back 3 years or more of the same metformin that they continue to receive every 3 months, thus checking the mark on whether their prescription drug was filled from a Medicare quality perspective, but without the actual last mile focus on whether they're actually taking those medications. So we spend a lot of time with our patients, particularly many of whom are obviously Black, Latinx, or Indigenous, and 50% of whom, and we know this because we screen over 100% of them, have at least one social risk factor, if not more than one. So this is not cherry picking. This is really dealing with the bulk of the challenge in American medicine for the populations who need it most. Next slide. We see this, across the way. This is not solely an Oak Street problem. Good data from Humana earlier this year shows that the majority of Medicare beneficiaries enrolled in Medicare Advantage are carrying at 2 or more social risk factors, right? And that oftentimes it is not loneliness and it is not housing security, although those are certainly quite large problems, but financial strain, right? And the simple work of ensuring that is everybody accessing the financial supplements that they're eligible for, and that they're screened and that they're actually getting those resources, becomes one of the biggest challenges, which is something that we focus on at length. Next slide. So we promise to focus on the details, and so I want to be candid in terms of how we do this, both at Oak Street and across the way. The first piece here, more than anything else, becomes really focusing on our differentiation of moving from reactive to proactive primary care, whether it's us, Aledade, City Block, the Chens, so on and so forth. We can take capitation in this setting, being at full risk, and enables us to invest in 3 things relative to typical primary care: time, resources, and follow-through. Time, as you can see in the setting of distinct differences in how many patients that we are taking care of from a panel perspective, that enables more focus and using the ability to leverage large and multidisciplinary teams to really dig in on the challenges, both social and medical, for those patients. Visit length, where for us, the average visit length is 40 or 60 minutes. The most common visit length is 40 or 60 minutes with each of our patients, and we're seeing them on average 9 times a year, as opposed to, from a Medicare standard perspective of 1.4 to 3 times a year. And then that shift to proactivity, right, where we are constantly looking to make sure people don't fall through the cracks, and our operating models are geared towards regular, frequent touch points. And so in a high-intensity model to ensure that people do not fall through the cracks and that our focus on crossing the T's and dotting the I's remains in place. Second is resources. Those big teams are teams of physicians and nurse practitioners and physician assistants, yes, but they're also nurses, rheumatoid community health workers, podiatrists, pharmacists, social workers, behavioralists, chaplains. We come together with each of us working at the top and the bottom of our licenses to ensure that we can actually fill in the details. We don't wonder whether our patients have gotten a test followed up. We actually can find out to ensure that piece of follow through, right? Instead of wondering about med affordability, we can connect somebody in real time, not only to our pharmacist to help identify what makes sense from a formulary perspective, but also to understand which pharmacies are available that will deliver in a home setting in a way that's convenient, and connect them to our social workers and patient relationship managers to ensure they've got the income supplements that they're entitled to reduce that cost of care. Instead of hoping that my patient with severe mental illness is going to see the state's BH clinic, we have behavioral health embedded in-house. I can do a warm handoff and deal with everything from SUD and SMI to garden variety depression and anxiety, to make sure that we're handling things in real time and doing so together. It's so easy as a practicing primary care physician to get caught up in the day-to-day of somebody who's presenting to me with an urgent issue, or who needs a form signed, or who needs something in that moment. So that without the intentionality to shift to proactivity and let the team structure get it there, we wouldn't get the results that we deliver. Because we catch people when they stumble. We try to help them when they're worried. Next slide, please. Of course, data and population health rigor obviously helps influence this approach. A lot of the work that we do is supported by, first and foremost, integrating a number of different data sources, publicly available and proprietary, to get a whole holistic picture on our patients. We leverage that in terms of helping us to understand what the dosage of primary care is, in terms of the frequency and intensity, that how we want to engage in longitudinal primary care, to help us put that picture together and determine the level of worry that we have for a patient. Population health management becomes a second piece, right, where we have a number of different tools that are expanding every day by which we can generate consistency to engender the proactive thinking at regular intervals and pull in the kind of democratizing tools like integrated specialty care through electronic consultations, home-based primary care, medication management, and the others, to really ensure we're working across a whole ecosystem. And third, really, that care navigation sport, right? So that making sure that we're holding the hands of our patients, we have the time to do the right thing, to do all the steps required. And it's that kind of work, whether it's happening by me, whether it's happening by Promotora or somebody else entirely, That's the hard, deeply meaningful work that we do every day in our sector, particularly at Oak Street, right? We enable the time, resources, and follow through a model that's optimized for this population, data-driven and intentionally holistic to build trust. Next slide, please. We see that trust play out in the kind of work that we can do even with a segment of the population that is obviously heavily underserved through traditional measures. We see on major, sort of national standards from diabetic control, breast cancer screening, colorectal cancer screening, and as our peers do in the value-based care space, that we can consistently take a population that is at higher risk and has more structural barriers to achieving 5-star performance and bring them to that level over and over again, state after state, over the past 10 years that we've shown. Next slide, please. We see this particularly in integrated behavioral health, where we know that by rigorous screening, more consistent warm handoffs, and integration of the behavioral health team and care plan into the primary care setting, we see substantial reductions in depressive symptom management from within Oak Street than from general population trends, be it even in the best places like New York City Health and Hospitals that have really championed both this measure and really focusing on patient reporting outcome measures. Next slide, please. We see these results outside of Oak Street as well. This is excellent data from Delegated showing their trends from a utilization perspective, that as they have driven a number of independent practices into more substantial, more engaged primary care relationships, what that effect has is on both ER utilization, inpatient utilization, and total cost of care. Next slide, please. I think the challenge for us is how do we move past these utilization measures, right, that we all quote against a data set that some would argue may not even be comparable from a traditional Medicare, into really demonstrating true impact on the patient and true impact on what their journey is and how we've actually bent that cost curve, that utilization curve. For us, for what we have, though, we can see over and over again, moving away from investing 3 cents on the dollar in American primary care, from a healthcare dollar, into flipping that paradigm on its head, as we've been able to do in the value-based care experience, yields consistently this kind of impact in terms of more than a halving of hospital admissions and in ER visits relative to Medicare benchmarks, dramatic reductions in 30-day readmission rates, even when we include observation stays in that space, and higher patient outcomes and satisfaction. Next slide, please. And for us at Oak Street, we've seen this. We will go here. We're running out of time. Next slide, please. One more. Sorry. There we go. For us at Oak Street, as a MSSP ACO for 5 years, we saw with deploying the same model without the benefit of risk adjustment, without the benefit of a lot of the things that often MA is labeled for, we achieved through the intensity of the care model the 4th highest savings rate of all 513 ACOs in the cohort, with a significant taxpayer savings to patient versus CMS target, showing that value-based care model can produce its consistent results over and over again. Next slide, please. One more, please, just in the interest of time. So despite progress in quality and equity, we are trying to be very honest that we think that the value journey has moved from toddler stage into gangly pre-adolescence and adolescence at this point. We're excited by this conversation today around thinking about what does incentive design look like in terms of expansion of Medicare-led payment models that more deeply link equity and quality, equity and payment reform in equal measure, as what we are debating today with Medicare Stars and what we're seeing in the first signals of ACO REACH. How we think about this from a scalability perspective when we think about the entire segment that still serves sub 10% of Medicare beneficiaries, and how we apply those lessons at scale to Medicaid and to high-risk commercial segments. And then thirdly, I think what really resonates is the pursuit of clinical excellence, right? I know a number of colleagues today will be digging in on this. What are the right measures? How are we evaluating clinical outcomes and equity in equal measure? How are we integrating those with patient-reported outcome measures? And what benchmarks are we driving towards? Can we do that collectively? Or should those be proprietary? We at Oak Street say no, if we're going to drive towards the future that we know we need to have. Thank you for your time today, and looking forward to the questions.
Thank you so much, Dr. Khan, for that very interesting presentation and perfect transition to our next speaker, Dr. Dana Safran, who is President and Chief Executive Officer at the National Quality Forum. Please begin.
Good afternoon. Thanks very much for the introduction. I'm really pleased to have the opportunity to be part of this panel today. And much of the information that I'm going to share with you really dates from before I was in my current role as President and CEO of NQF. And in fact, from a time when I was on the executive team at Blue Cross Blue Shield of Massachusetts. I'll be talking about some of the particular methods that we used in our global budget contract called the Alternative Quality Contract, or AQC, that I think really differentiated that model's ability to achieve the twin goals that we had of improving costs and improving quality and outcomes while reducing cost and cost growth. So that will be the first segment. Second, I'll talk a little bit from the perspective of what are the highest priority gaps that I think need to be filled for value-based payment models to be successful. And then finally, talk a little bit about the issues around health equity and adjustment for social risk. So if we go to the next slide, please. I'm going to assume, given your backgrounds, that most of you are quite familiar with the Alternative Quality Contract. So I won't walk through that model, but for any who aren't familiar with it, this is a model developed in 2007, launched in 2009, so well before the ACO movement was underway, and in fact a catalyst for that movement because of some of the results that I'll share with you that emerged from this work. And the things that differentiated the model from, at the time, what were the traditional fee-for-service payment models were provider systems being paid on a global population-based budget, having symmetrical two-sided risk on that budget, having a significant opportunity for upside earnings based on quality performance on a very broad set of quality and outcome measures, and having long contracts, 5-year period contracts with a fixed cadence of inflation predefined before the contract started so that providers understood what growth would look like over each of the 5 years and designed to come down over time so that by the end of the period, growth looked like general inflation and not the 2-3 times inflation rates that we had in 2007 when we began. So next slide shows you just a snapshot of the, next slide, please. Thank you. Shows you a snapshot of the quality measure set that I developed in 2007, and that was really at the heart of this payment model, the opportunity for quality to be the important backstop against any impulse to stint that might occur from a global budget set of incentives with two-sided risk. What you see is that there were 2 settings, ambulatory and hospital, and for each setting, we had a range of process, outcome, and patient experience measures. Today's measure sets, I would argue, look very similar to this measure set developed in 2007. And that's what I'll be speaking about in the second segment of this set of remarks. But if we go to the next slide, one of the things that I really wanted to emphasize for this audience is that there were some particular methodological innovations that we used in our incentive model that I think really contributed very importantly to the success that the AQC had in driving improved quality and outcomes. 2 that I would highlight are, besides having the broad quality measure set that you saw in the previous slide, for each measure, we had a range of performance targets, not a single number. That was novel at the time. At the time, performance-based payment really typically had one performance target, and a provider either made that and got rewarded or missed it even by hundredths of a point and got nothing, which was very demotivating. So having a range of targets was very important. The other thing that was important that we did was we based those targets on absolute performance, not relative performance. In the Q&A, we can talk a bit about how we did that if you'd like, but the net effect of that was that it was not a tournament among providers in the model. So as a result, our providers in our network statewide were very willing to collaborate and share best practices because one organization's success at gaining ground in the quality measure set did not come at the expense of another provider. And what you can see is that across the range of performance targets from what we call gate 1 to gate 5 on the x-axis, providers had the opportunity to earn up to an additional 10% on that global budget, which was tens of millions of dollars in most cases. Next slide. I won't spend a lot of time here, but one of the reasons that the AQC model was as influential as it was nationally and even internationally was that we had the great good fortune to have a team from Harvard Medical School studying the results of what we were doing while we were doing it, publishing year by year by year, and showing, in fact, that this model was improving quality and health outcomes. You see that panel roughly the middle of the screen with the blue line signifying improved outcomes in our cohort, the orange line signifying outcomes in a national set of benchmarks. And what you'll notice is a very, very steep increase in the performance on outcome measures from the third data point, which is the year that the contract launched, all the way through the follow-up period. And this improvement in outcomes really required novel care models, very much like what doctors Grossman and Kahn have described, where we think outside the literal and figurative box of the clinical setting to where patients live and work in order to address the unique individual barriers for each human being of what stands between them and good outcomes. That's very different from the care models that we get, as we know, under fee-for-service. We also saw significant cost savings, and those are captured in a series of New England Journal and Health Affairs articles, the latest of which was an 8-year retrospective that showed 12% cost savings over traditional fee-for-service contract models. Next slide, please. Actually, I think in the interest of time, I'll skip this slide. I can come back to it later. This is about how we shifted the incentives after several years, but we can to link the shared savings to quality performance. So we can talk about that if that's of interest. This slide I'll just speak briefly because I think Drs. Grossman and Kahn have really articulated the kinds of care delivery innovations that lead to the really significant improvements in quality outcomes and costs that we are talking about. But these are the 4 broad areas that summarize the kind of interventions we saw our network making from the very first year and all the way through. Next slide. So one of the really critical, this is the second part of my remarks, gaps that we have is, as I pointed out, measure sets today look very much like the one that I developed in 2007. And yet, for over a decade, we've been saying we need to move to more outcomes-oriented measure sets. When I was contributing to some work of the LAN, we called these big dot measures. And the value of moving to big dot measures for value-based payment is really manyfold. But one of the points of value is the measures in measure sets today and in the one I developed for the AQC really are the product of a fee-for-service mindset, very much process-oriented. You do a thing, you get paid for the thing, we measure the thing. Whereas really what we're trying to get to in value-based payment are the outcomes. And fortunately, those allow for a much more parsimonious measure set because, you know, a global budget contract, if you're measuring on process, it's going to have to measure an awful lot of things. Whereas if we move to big dot outcome-oriented measures, we can be much more parsimonious and much more consistent with the real intention and purpose of value-based payment. But despite nearly a decade of consensus that that's where we need to go, we haven't gotten very far. Next slide shows that there are 5, next slide, please, shows that there are 5 broad clinical areas that represent more than 50% of medical spend for both commercial and public sector payers. And yet very few, if any, outcome measures exist in NQF's endorsed portfolio of measures. So this is one of the priority areas for me as the CEO of NQF, hoping to make progress on this in the years ahead. I know we're at the end of my time, so I'll just say a few words about health equity if I could. Let's jump ahead 2 slides, please. This is a set of results that were published in Health Affairs from the AQC, and what I want to draw your attention to here is the yellow and the green line at the top. And what that was showing was that the AQC was succeeding in narrowing longstanding disparities in healthcare quality among our our most vulnerable patient populations relative to the most advantaged patient populations. You can see from the blue and the orange line just below that, no such closing of the gaps was occurring outside of the AQC. And it helped to shape my own perspective about how we address social risk in payment models. What I share right now is my own perspective. If you could jump ahead 2 slides, please. My own perspective and not that of NQF. It's why I don't have NQF's logo on this final slide. But my perspective is this, that at this time where we are all prioritizing improvement in health equity, we can invest in health equity by adjusting payment, not adjusting measure scores for social risk. We can adjust payment in either of 2 ways or both, by having providers with higher social risk receive preferred base payment rates or a lower benchmark, as is done in the ACO REACH program. We can also create a multiplier so that for a given level of performance, those with a higher social risk are earning more for the same level of performance. In this way, I would say we have our cake and eat it too on the concerns expressed by both sides of the argument. Those saying, you know, we need to adjust for social risk. Those saying we can't adjust for social risk because if we do so on the measure side, that we mask and conceal the important differences that can be there. We can have our cake and eat it too by adjusting, but on the financial side, and in so doing, invest in health equity as opposed to obscuring disparities. So thanks for your attention. I look forward to our discussion.
Thank you so much, Dr. Safran. That was very interesting. Our last listening session presenter is Dr. Adam Weinstein, who is Chief Medical Information Officer for DaVita Incorporated and an advisor for the Renal Physicians Association. Please go ahead.
Thank you, and thank you for inviting me to this conversation. Today I'm wearing my Renal Physicians Association hat. We are an advocacy organization representing nephrologists throughout the United States, and I think in contrast to my colleagues here, I bring sort of the tactical frontline physician representation of what these models can mean for doctors and patients. I want to take a few minutes to start with, and if you could move to the next slide, please. The definitions. So the world of nephrology is an acronym-laden world filled with lots of very specific definitions, and I'm not going to go through all of these, but I wanted to include this in the slide deck for future reference. The 2 you're going to hear me talk the most about is CKD, which is chronic kidney disease. I think many of us are familiar with that term, but ESKD and ESRD are used interchangeably, and it is the state in which a patient no longer has enough kidney function to sustain them without dialysis or a transplant. The rest of the vocabulary there is there for your review if you need it throughout the rest of the presentation. Next slide, please. So I want to start by talking about the physiology and the logistics of kidney care delivery. In contrast to, I think, many of my colleagues here, we represent a large group of nephrologists that are in a variety of practice conditions. Some are part of large health systems. Many are independent practices that work in communities throughout the United States. Some practices are as large as 30 to 70, if not more, nephrologists. Most practices are between 4 and 7 nephrologists delivering care in a variety of settings from rural to urban. The problem with kidney disease is that it is a continuum of care that requires ongoing monitoring. We have really good ways to keep track of people's kidney function using creatinine clearance or the estimated glomerular filtration rate, which then breaks out into stages of chronic kidney disease. When someone has somewhere early stage 3 to mid stage 4 kidney disease, they are in a window where we can do the most to mitigate risk and avoid potential expensive costs. As people's kidney function begins to fail further and they enter late stage 4, stage 5, and as they enter end stage kidney disease, we know this to be the period in which their medical complexity is high, and the costs associated with the care can be very high if upstream work, that is work in that period of greatest potential for risk mitigation, is not taken. There's a series of jobs to be done, things that nephrologists, as the quarterback of care, especially for stage 3 and beyond patients, can be doing to either slow progression and/or prepare patients appropriately for what's called an optimal start, which is a period where they can start dialysis or get a transplant with the least amount of cost and the most amount of medical support. The biggest problem we have in the world of nephrology is that it takes a lot of colleagues in other domains to care for these patients. And so irrespective of how good a nephrologist is, you're only as good as the community of providers that are working with you. Nevertheless, the nephrologist is in fact the best quarterback for managing this particular disease state, since it's what we do, it's our bread and butter. And so no matter what payment model that we are participating in, and in the appendix to this deck, I've included what is 17 years of numerous payment models that nephrology has been participating in one form or another, the nephrologist has to be at the center of it to make it work. Next slide, please. So I think it's important to talk about why kidney disease as a disease state rather than a population works well as a total cost of care model. There's a number of features about nephrology care and really kidney disease patients that lend themselves well to this kind of payment scheme. Number one, there's obvious significant financial incentive or savings to be had when care is delivered appropriately and optimally for our patients. Dialysis, as you know, is very expensive, and transplants are less expensive, especially if done preemptively. Moreover, when patients have to start dialysis, if done in a way that is planned and thoughtfully executed, there's significant cost savings to be had as well as quality of life for the patients. Numerous, tens of millions of patients have some degree of chronic kidney disease, and these patients are typically diagnosed years before they enter that window of highest cost and highest complexity. Our patients are easily defined by lab data, and there's administrative data to keep track of their progress, both in the form of claims as well as CPT and ICD-10 codes. There are measurable and cost-effective solutions that can slow the progression of kidney disease, and of course, we understand at least some set of best practices that keep patients healthy on dialysis and getting transplanted. And lastly, attribution is relatively simple, though not perfect, but we have numerous TCOC marks on the timeline that I displayed on the previous slide that allows us to link patients to physicians and other care providers in the communities in which they live. Next slide, please. So I probably should have termed this slide the actors rather than the ideal components, but I think it's important to see the list of people and stakeholders that go into caring for kidney disease patients. Obviously, CMS and payers have a strong interest in ensuring patients get high quality, optimally priced care. The patients and the caregivers, I think, are critical components of this. Much of what we do in nephrology involves engaging patients and behaving differently, taking medicines, a lot of the things my colleagues have discussed, but perhaps more so given the complexity of their renal disease. Nephrologists and providers, and more importantly, their nephrology practices, are business entities. These entities are built around fee-for-service medicine by and large, and most of the payment systems that have been put into place over the last 17 years carve out a small percentage of the practice, which I'll talk a little bit more about in the next slide. But really, I think it represents the fact that when you're a nephrologist or nephrology practice participating in one of these programs, that you're being asked to take a subset of your patients, think and work differently about that subset while you're still caring for the rest of your practice in the more traditional fee-for-service model. There's a new entrant in the kidney care space, which are kidney care companies. Some of these are dialysis organizations like the one I work for, DaVita. Some are independent organizations that are helping nephrologists and nephrology practices both take on the logistics of managing patients in population health, as well as bearing some of the financial risk in the newer model models that have come out. And lastly, we interact heavily with other specialties and health systems. Within the kidney care payment systems, these folks have often been neglected, really. They are marginally incentivized, and while they're critically important, our patients are hospitalized quite frequently, they're often not as involved in the processes that need to be put in place to reach maximum success. And if you could go to the next slide and my last slide, please. I want to close by talking about where the features that have been most successful have come from over the last 17 years. I think you're going to hear a lot of the same themes that my colleagues talked about. And I'll start with the nephrologists and the nephrology practices. For independent nephrology practices, really, these are the folks that want to be the quarterbacks and provide the most frontline care. And we're asking them to flex into population health activities, flex into delivering care between office appointments. That means they need to have IT that works well and it integrates with other community members. It means they need to have the right tools and data available. For them, meaningful rewards financially as well as quality of care rewards are important. Most nephrology practices are willing to take moderate risk but are not really capable of putting up investment up front and are really dependent on simplified reporting and accountability burdens to be successful. The kidney care organizations, that is the newest entrants in this market space, really have started to fill some of the gaps, but are not quite there yet. They are more willing to take on risk and invest up front. They are willing to provide the IT and analytics that most small and moderate-sized practices can't provide. And they really need to take the time to contract with all the other entities in the space. Health systems and payers are still not fully engaged in the nephrology care space for capitated and at-risk payments, but really they are critical for providing data such as ADT notifications and partnership for delivering care through some of the subspecialties that are so critical for our patients. And lastly, I think you've heard numerous comments about what patients and care providers want, and certainly our patients are no different than I think many of the patients represented amongst my colleagues here. We really look to be able to incentivize and work with patients differently within these care models. I'll close by saying that I think the most common word I heard today amongst all of our presentations is time. And I would say that from the perspective of a kidney doctor, all of these things take time to develop. And so no matter what care models are developed, they need to be thought about in 5 and 10-year increments, not 1 and 2-year increments. They need to be thought about as laying out a set of boundaries that are adhered to for a number of years so that you can build IT systems that cross all of the entities in these communities, as well as give time for the practices to adjust their workflow, as well as to engage patients in what is really lifelong behavior changing that's necessary to successfully navigate one of the new payment models that might come down the line. So with that, I'll stop. I will refer you to the fact that I have a few slides in my appendix that might add some extra value. And likewise, I'm happy to take questions as part of the question and answer. Thank you.
Thank you so much, Dr. Weinstein. It was very interesting. I want to thank all of you for sharing your experiences and your unique knowledge with us today. Now we're going to open it up to committee members to ask questions. If you'd like to pose a question, please tip your name tag straight up, and I want to open it up to the committee. Angelo.
Yeah, my question is for David Grossman. So I heard about the automated mechanisms for sending referrals to the community-based organizations. I was wondering how you partner with them to hold them accountable for actually delivering services and outcomes.
Yeah, thanks so much for that question. I think that's a work still in progress for us. Our first order of business is actually to create the incentive and the means by which to get these community-based organizations actually even to be part of the network and involved. I think a secret to success there is to try to work in collaboration with the rest of the community and not have this be seen as necessarily a delivery specific backbone, but one in which we can try to recruit other delivery systems and plans to be part of the same network. I think that enhances the ability for us to be able to have that level of accountability and expand the accountability to be not just from a single delivery system or plan to a broader community level of accountability. As we as you well know, the issue around in lieu of services and how these types of community resources may be converted into coverage benefits will probably play a role in terms of how the accountability process evolves. But for now, it's really as we unfold this process and engage our partners in the community. I think that the process will involve giving feedback and providing statistics and data about the level of engagement, the referrals have been, the percentage of referrals have been accepted, the percentage of information that comes back into the record as starters, just in other words, these process outcomes to make sure that in fact these services are actually being delivered. It's going to be a little bit more difficult challenge to assess quality in terms of those services. And I think that's something that we as a community are going to have to really think hard about. Thank you.
Thank you so much, Dr. Grossman. Paul.
Yeah, hi. A question for Dr. Khan. Thanks for the great presentation. You know, on your slide 10, when you talk about value-based models, under population health interventions, you list integrated specialty care. You know, we talk about under these total cost of care models amongst the committee about how to engage specialists, how to think about how specialists fit in to the total cost of care model. And so I would just be curious to hear more around how you engage with the specialists in general. And I know some of this is virtual, but then how much is virtual versus in person, and how you work that into your care delivery model.
It's a great question. Thank you for it. I actually probably love a bunch of points that resonates with what Dr. Weinstein put out, because from a ground level perspective, a lot of this comes down to what is the kind of connectivity that we're getting, right? How do we drive towards bidirectional communication? And are the specialists that we're working with, nephrology is a good example. Are they are those individual nephrologists, excited by what we're trying to do, aligned from that perspective, and eager to dig in, right? Because I think we do see across lots of specialties heterogeneity in terms of whether some folks are really excited by the idea of robust generalism, and bringing hopefully higher quality consults, things that are more worked up, things that are more focused, and some are not, right? Like in terms of the traditional fee-for-service system, even when there are those that are, right? Traditional methods of communication, traditional methods of information transmission, stuff like that, will often stymie, right? I can spend 15 minutes writing a beautiful consult on a very specific thing that I need a kidney biopsy for, and if that gets transmitted as CKD3, everything is lost, right? So on that level, I think we deploy a couple things. So first, we do leverage electronic consultation in a couple different ways through the partner organization that we've now acquired, Rubicon MD. So asking questions both highly specific and very general in order to ensure that our primary care clinicians aren't worrying alone in terms of just asking the questions they want to ask, whether what's the next medication that I should add for this diabetic, to hey, I've got this patient who I think may have lupus nephritis, and I'm curious about whether you would start something versus just, versus wait for biopsy, given sort of the family history and everything else that we're seeing, right? That kind of spectrum in an e-consult platform is something that we're able to get back, not in the 10 or 11 weeks that it can often take for a patient of mine to get prior authorization from a plan, scheduled, follow-up, and then, actually seen, and then with those records back to me, but oftentimes in 4 to 6 hours, right? That starts a conversation. Now, when we pair that with the legwork that we do in every city, in every community that we enter, of going out, taking publicly available data, taking proprietary algorithms from folks like Care Journey and Gartner and others to try to identify who are specialists that are potentially high value practitioners, right, as defined by those proprietary agents. How do those patterns or those findings match up against the clinical experiences of me, my team, my colleagues, in terms of who's good to work with? Then we layer on a bunch of work in trying to build relationships with targeted foci, right? So I may go in Maryland to Dr. Weinstein's practice and be like, hey, this is who we are. We'd love to work with you. We can do this in a couple of different ways, but again, communication, rapid turnaround, and good engagement on both sides are going to be really crucial to make sure that we're driving towards exactly that vision of potentially co-quarterbacking, passing the ball back and forth, so on and so forth. When we do that work, we now are able also to say, hey, we can preferentially put you all on this eConsult platform if you'd like. A good segment of our volume can go to you. And so that way we're establishing the bi-directional communication necessary up front in that eConsult platform, where the specialist can then tell us, hey, it's time for this person to really go to procedure, go to biopsy, needs to come in to get listed for a transplant, so on and so forth. And we can turn that around quickly. So it's not one main solution, but it becomes this piece of how are we leveraging, tools that we have today from a digital perspective to democratize and speed up access to specialty consultation for patients that are often without. And then secondly, how can we use those tools plus good old-fashioned analog interaction and shoe leather to build the relationships necessary in any community health environment to actually get that piece of follow-through. And so those two together are what have been showing most promise for us, particularly as we get to scale in certain places, right? Like here in Chicago, where we take care of 60,000 lives, that's a much easier conversation to have than when we've opened up, a few weeks ago in Phoenix and we take care of 300 people. So some of that matures as we go on.
Josh.
Great. I want to thank all of the speakers for great presentations. My question is also for Dr. Khan. I appreciated you sharing the data from the ACORN network in the kind of fee-for-service space and comparing that to MA. And, for me personally, I think a lot about the key differences that might prevent someone from using the same thing on both sides. And I'm wondering if you can comment on, in that slide that Paul reference slide 9, where you're identifying time, specialization, support, technology integration. If you can kind of cover some ground mentally with me and say, what are the things that you think you've seen from Oak can be done pretty similarly across MA and fee-for-service, comparably to see those benefits that you're showing on that slide? What are the things that you've done successfully in both, but really need to look different in delivery? And then what are those things that you say, look, in a ACO setting, it's very hard for us. We found it's hard to do, and so we don't do those in that setting where maybe we could under MA or other things. So kind of, if you could bucket in those 3 ways, that'd be very helpful.
Yeah, and I'll give the caveat of easy to do it versus financially sustainable to do it. There are 2 different things, right? I think from the context of the core of what we do, right, in terms of bringing a patient in, risk stratifying them, identifying the amount of the right bolus of primary care, building the longitudinal care management plan that integrates with that clinical care plan, right? And then setting the core of the large team, particularly nursing, community health workers, social workers, and in addition to our primary care clinicians, against that work. It consistently works across both settings, right? We can do that over and over again. And that for us, has seen similar results as demonstrated by, our performance in MSSP around delivering, delivering that consistent experience and that consistent pace of follow-up has worked for us on both sides. I would say where we end up running into challenges is probably in the areas of when we start to layer on additional services that we just financially can't sort of take on further in a non-MA or a non-capitated environment, right? So for us, historically, that's often been integrated behavioral health, where we are, doing a lot of work to refer people out, but making sure that we can, bring that in, where we are doing a lot of work in training up our own folks using national, urban, and rural ECHO programs with UChicago and the University of New Mexico on how to manage and treat SMI in primary care with, our own internal consults, at least from a curbside standpoint, how we leverage electronic consultations, Rubicon and others. That's one area. Podiatry becomes another area. Some of the ancillary stuff that we do, particularly on transportation, right, is often something that we can't open the gate for from a Medicare fee-for-service perspective because the economics grow challenging. So I think it becomes the basic model, right, of higher touch, higher intensity, proactive primary care using a large team-based model can deliver a lot of good. I think when we look at some of the aspects that we feel are core differentiators to driving the next level of value and integration from a patient-centered perspective, particularly when we think about navigating the specialty world or navigating just last mile challenges when it comes to transportation, medication delivery, financial supports, that's a challenge, right? For example, when I was in clinic yesterday, I had a patient with, recent asthma exacerbations, had lost her nebulizer years ago from the health plan that she had gotten previously. She's on Medicare Advantage with a Blue. And for us, since we're at full risk, I just go back, I grab the nebulizer and I hand it to her, right? Like, and we fill the script for the nebs from a medication perspective in the pharmacy. She goes out, she's got that set up. I can't do that on Medicare fee for service today outside of alternative payment model constructs, and that I think becomes sort of the typization of the challenge.
Larry.
Thank you. Like Josh, I'd like to thank all of you for excellent presentations. Your experience brings information to our committee that's extremely valuable for us in making our decisions. I have two questions. The first one is for Dr. Grossman, and I'm focusing both of my questions from the view of the specialist. So if I'm a specialist inside Kaiser, and I obviously have an opportunity to work elsewhere other than Kaiser, what are the benefits to me as a specialist in working in this environment? Do I have some freedom from some of the pre-authorization problems that exist in the private practice world? Do I realize more incentive payments from value-based care than I would in the private practice space? How do you keep your specialists on board?
Thanks, Dr. Kosinski. I think that, and that's obviously a really important question. How well does the model work to retaining and the workforce, and also making sure that it's a satisfactory experience? And I think that, of course, there's been a ton of emphasis on primary care medical home and potential rewards associated with an advanced primary care practice. Perhaps less emphasis on sort of what is the process for a specialist and how does it keep them engaged. I think that freeing specialists from the constraints of a fee-for-service system is in and of itself rewarding, in part because Kaiser Permanente, so the Permanente medical groups do not impose volume requirements or, although we do track overall our view and productivity, we generally do not, mostly from a standpoint of setting minimum thresholds, we do not obviously incentivize the increased use of services and do not put our specialists onto a hamster wheel to generate more volume. I think the other issue is in trying to create a unified medical group and a multi-specialty group, enhancing the relationship between specialists and primary care, much as Dr. Conner was just describing earlier, is super important, I think, for our group's overall level of satisfaction. And specialists can also play a mentorship role. For example, in the region where I work for the National Program Office in Kaiser Permanente, I recently moved from the Washington Permanente Medical Group over to the health plan side in Oakland. I prefer year practice here in Seattle. And for example, our diabetic practice is radically different than what you might see in a traditional environment where the diabetologist actually sees the more severe, complicated cases and trains and actively supervises a cadre of internists and family physicians who are, in a sense, deputized to take care of the more, and including advanced level practitioners, those that are less severe, and enables our practitioners and our specialists to practice to the top of their license, and really also enriches the practice mix for primary care physicians at the same time. So, the type of model that we use here, I think, is one that definitely does appeal to specialists in general. And we generally are very competitive in attracting applicants for specialty positions. I hope that's helpful.
I think it is. I'd like to address a slightly different twist on the question to Dr. Khan. Since you engage your specialists, and it sounds from your presentation like you have a tremendous relationship with select groups of specialists that see the world the same way as Oak does, what percentage of their business typically are they obtaining from Oak? Are your specialist groups almost exclusive to Oak? Are they deriving a very significant percentage of their business from Oak? Please expand on that.
Yeah, it's such a good question, and I was, as Dr. Grossman was giving his answer, I was smiling to myself only because the idea of having the captive specialist network as he does would be such a gift. Before my time at Oak Street, I spent a number of years at CareMore Health in California, part of Anthem Blue Cross Blue Shield. But in a world in which you as a health plan and a clinical provider, we had the kind of relationships, Dr. Kaczynski, that you allude to, where oftentimes the percentage of volume that a certain specialist group might be getting from us at CareMore was running upwards of 45%, right? Because of the strength of those relationships and the strength of those networks. At Oak Street, I think because we are so geographically dispersed across 20 states, but even in our most dense market, right, still only serving 60,000 beneficiaries, there's not a single specialist that we work with today where we represent anything more than 10% of the volume that they have, right? And I think therein lies a very key difference where 10 years ago, it was almost always outlier practices that were willing to engage in this way. Now, we are seeing health systems and multi-specialty groups who have become a little bit more forward-thinking. Like that shift has gone from like 1% now to maybe like 35%, who see like, hey, this is a great model for us to test out, to see what we can learn from, and then do we try to leverage something similar within our own groups? Do we leverage this across our book on MSSP, so on and so forth, right? Where they're willing to kind of prototype with us, and we bring sort of the prototype hypothesis over and over again in communities across the country. But where we haven't developed the kind of relationship where it's like, we're the bulk of their business. I do think we are seeing this across the value-based space in certain places, particularly when you look at the large MSO aggregators. So Agilon, for example, in Ohio, I was talking to their CMO the other day. They're able in a market like Akron to bring 40% of membership in that region to a specialty group and be like, hey, work with us because we control a pretty big chunk of change. We're not that lucky, so we have to go a lot more on sort of focusing on the details and getting to programmatic excellence to demonstrate that the unit investment is worth it to work with us.
Thank you.
And Josh, did you have another question?
I was just wondering if I could just add one other comment to Dr. Kaczynski's question, if that's okay, Dr. Hurd. Two other issues. One is I think it's important to recognize that because Kaiser Permanente is a nonprofit organization, we are somewhat constrained in terms of what we can do in terms of offering financial incentives, and our salary structure is actually competitive. But clearly, physicians that come to work for Kaiser Permanente don't come because it's the best paying offers in the community. Instead, what they're doing is trading off a practice and lifestyle and philosophy practice. That is rewarding to them, but not necessarily the highest paying and offer in the community. The second issue, I think the other big difference that I neglected to mention was the seamlessness with the integration of the health plan and the practice is really important. The lack of needing to fight and appeal and go back and forth and bicker with multiple insurance companies, I think no doubt also contributes to the level of satisfaction as an attractive feature for someone working in a Permanente medical group. Thank you.
Very helpful. Go ahead, Josh.
My next question actually is for Dr. Safran, and thank you for reviewing kind of your experience with the AQC. And I guess my question is, within the context of a global budget, and one of the themes I'm taking away from these sessions is that it provides some flexibility financially to do a number of things. I was struck by the fact that there were, as I understand it, additional PMPM quality dollars, kind of regardless of what the budget deficit or surplus was. And I'm curious if you could just share with us, given that PMPMs are something that we're thinking about in these models, what are certain things that partners are able to do with those PMPM dollars, maybe that they wouldn't have been able to do without them? Or, based on those learnings, how might we think about PMPMs going forward in these TCOC models?
Yeah, Josh, thanks for that question. And I'll answer it in two ways. First, what I'll say is that I think the PMPM dollars provided enormous opportunity to invest in those four different types of interventions that I highlighted in a slide that I only went lightly over, but new kinds of staff, new ways of engaging patients, information technology and data systems and new ways of relating to others in the network. Probably the least was invested in the latter of those four categories. But, new staffing models, I think you've heard quite a bit about that today, bringing behavioral health specialists into primary care settings, bringing pharmacists on staff, bringing social workers and others in sort of allied behavioral health specialties on staff. So staffing, patient engagement strategies that leverage those new kinds of staff that involve, for example, direct patient outreach, in between visits, after a hospital discharge, really the things that had the care extend outside the clinical setting to provide the kind of support that I referenced that I think contributed to that improvement in outcomes that we saw. So that's one thing I would say. The other thing I would say is that the constraint of our model was that those dollars, those payments were generally made, in the year following. They were a reward for performance in the last measurement period. And some of, I think, the attraction of models that are not a global budget, but rather an actual capitated payment, are that they address some of those cash flow issues. And perhaps, I think, I don't personally know of any evidence that demonstrates that does create a front loading of those investments. But that's, I think, the intent. What we did as a kind of surrogate for that was, especially in the early years, we created some infrastructure payments that were grants, if you will, but sums of money to help organizations invest in electronic health records. Because remember, this was 2007. It was still very early for many organizations, or invest in other things that they needed and where we didn't want them to have to wait until a performance-based payment, next year or 2 years down the road.
And Paul.
I have a question for Dana as well. Dana, it's nice to see you, and thanks for a great presentation. One of the topics we talk about a lot is accountability and level of accountability, whether it's the entity level and how do you cascade accountability. So when you think about quality measures, and you mentioned the advantages of outcome measures, often, as I think about it, it's often challenging to think about what is the right level of accountability when it comes to outcome measures, as often it's hard to assign that to a specific provider. And of course, it depends a bit on what the outcome measure is, but I know you've thought about this a lot. I'm just curious about your thoughts in general.
Yeah, thanks for that question, Paul. So what I would say is that in the AQC model, the accountability was with the system. And the system, as you probably know, could include anything from a large enough primary care practice, meaning had at least 10,000 members so we could compute actuarially sound budgets, and was willing to accept accountability for total cost of care across the continuum, even though they didn't have, specialists or hospitals in their contract, all the way to, a multidisciplinary practice or a system that had multiple hospitals and everything in between. So accountability at that level for outcomes. And I would say that both with respect to ambulatory outcomes and hospital outcomes, that was kind of appropriate and fair. Where I think your question comes into play is, what about for the individual clinician or the individual team that's actually directly involved with a certain episode of care and the outcomes from that? And that's where, I would say both the art and science of measurement that I've dedicated my career to tells us that that's not a good idea. That, the science part is we rarely have adequate sample size, especially for an individual payer. An individual payer with an individual clinician or even team to compute stable, reliable information about performance on a given measure. But but also from the perspective of Art, it doesn't create the incentives that we really want to be creating now, and that value-based payment, I think, is trying to drive, which is really knitting that fabric that is healthcare that no single individual clinician or even any single team can provide. So I think by creating the incentives at the system level, that's appropriate. The challenge, which I know you're well aware of, but that I can't end this response without saying, because it would be incomplete, is that how that institution cascades those incentives down to the individual clinicians matters, right? Because when the payment for the individual clinicians is primarily based on RVUs, for example, we are really living with, a foot in two canoes. It's very different from the sense that phrase is usually used, but you've got individuals incentivized completely differently from how the organization is incentivized, and I think that gets us stuck and unlikely to see the progress that we want from value-based payments. So I think it is important for organizations to cascade the right incentives down to the front lines, but not by creating accountability for individual measures and the results of those measures. I hope that answers your question.
Yeah, thank you.
Walter.
I have a question for Dr. Khan around the flow of funds in the Oak Street model, both to the organization and then, as Dr. Safran was just mentioning, how Oak Street incentivizes the frontline primary care provider. So the first part of my question is just a kind of a real simple structural one. Does Oak Street Health have its own health plan, or does the organization take delegated risk from incumbent Medicare Advantage plans?
Great question, Dr. Lynn. Always happy to take it from a fellow Yale internal medicine grad. By and large, so we are not a plan, first and foremost. We obviously, for the 120,000 or so members that we are at full risk for, we are in full percentage of premium arrangements with a variety of health plans, I think 40 plus around the country, including all 6 major nationals. For a subset of those plans, we happen to be delegated for a partial set of functions, most often usually in care management, utilization management. It is very, very rare that we are taking on network claims, grievances, appeals, those sorts of features. So, which creates a different locus of control and a different areas of focus than necessarily what I enjoyed coming from the plan perspective at CareMore a few years back. So by and large, then occasionally there are upfront capitation payments included as part of those percentage of premium arrangements, but that is the main structure. And then there are some plans for which we are in a primary care cap with a small number of plans kind of across the country, often as a bridge towards driving towards full risk arrangements in the following year. Then
thanks. And then the second part of the question is around how Oak Street incentivizes its primary care focus model to engage the frontline PCP to reduce ER utilization, inpatient hospitalization, total cost of care. What kinds of it doesn't have to be too specific, but in general, compensation arrangements do you have, and how have you seen that change primary care provider behavior?
Great question. So I think similar to the Kaiser model, we feel like we are offering, competitive above 50th percentile salaries from a primary care perspective across the workforce, which makes a difference. It doesn't close it, but it does make a difference in terms of sort of the shifting of primary care reimbursement. And thankfully, I guess for whatever reason, the Kaisers of the world, the Oak Streets of the world, and the Ioras of the world have induced somewhat of a sea change on the fee-for-service side towards better primary care salaries. I say this as a general internist, although most of those places, they're heavily RVU weighted. For us, obviously, there is no RVU component. We do maintain a significant portion of total compensation in bonus eligibility, but those bonus measures are driven almost entirely by engagement, quality, and quality measures, right? So how have we done from a panel perspective in terms of at the individual level and at the center level of bringing all of our primary care patients back every year for staying in programs, having completed their annual AWV and, really having engaged in that way, right? We may look at performance on STARS measures across the panel and how we're driving from that perspective in a risk-adjusted manner, right? It's these kinds of measures, right, that we really try to drive towards. We did a couple quarters last year where we really focused heavily on COVID vaccination and boosters, right? So in terms of what we've seen is that in terms of driving primary care and team behavior, those same bonus measures are cascade across the entire team, from our welcome coordinators who are checking in patients to our drivers who are providing transportation to our social workers, so on and so forth. Different weights and measures, but by and large, really optimizing on that aspect of patient experience and consistency of follow-through. And so with that, we are able to derive a whole team kind of engagement in the pursuit of those measures, which I think unlocks a bunch of creativity at its best, right? When a team is like, you know what, the whole point of a model like this is to let's just go to their house and we can block off 2 hours because that's the right thing to do, because we know he's having trouble coming in and we know his patient's hard of hearing and he's got other challenges, right? Or sometimes it can be what I did a couple weeks ago, right? Which is knock on a bunch of doors in a parking lot in a semi-abandoned mall in the west side of Chicago, looking for a patient of ours with our social worker and with one of our promotores who we knew had a pretty honking diabetic foot infection, and was in a gray Celica, but she thinks it's a Celica, but she really only knows it's a coupe, right? And so we're literally walking around this entire mall parking lot trying to see who's in every single one of these gray coupes, because that's the right thing to do from an engagement standpoint. So what we found is that that kind of approach can be very useful in starting to do the work of unlocking years of reactive practice into doing something more that feels very odd to our PCPs in particular, but that is actually the work, I think, and the Kaisers has exemplified this so well, of just getting out in the community and meeting people where they are.
Great, thanks. Those examples were really vivid and I think well illustrative.
I think this is a perfect note to close this session. We want to thank you all so much for this excellent discussion. I have a feeling we could continue asking you questions for a good another hour. We want to welcome you to stay on and hear the next presentation or listen to the rest of the meeting as much time as you have available. We'd love to have you on. And we want to sincerely thank you for sharing your time, expertise, and excellent thoughts about total cost of care. Next, I'm honored to move into our PTAC member listening session, and we have one of our very own members presenting based on his experience with many delivery system models. Angelo Sinopoli, committee members, will be presenting, and members, please have your questions ready for Angelo after his presentation. Angelo, please go ahead.
Thank you, Lauren, and I appreciate the opportunity to talk today. And right now I am the Chief Network Officer for UpStream, but I want to emphasize that this presentation is not really about UpStream, although I'll highlight some characteristics of UpStream that fit into the discussion here. What I'm really trying to bring to the table today is kind of a series of experiences working with very large integrated delivery systems, large networks, enablement companies, consulting with other networks, particularly across the Southeast, but other areas, and then my more recent experience with UpStream, and kind of identifying, I think you're going to hear repeated messages from today. I think we're all on the same page in terms of where things are going and what needs to happen. So I'll just walk through this and kind of highlight these things as we go. So if you can go to the next slide. So this is just a pyramid that I always like to look at because it does represent all the building blocks that are necessary for a very high-functioning integrated network. Now, I'll tell you that from my experience, with notable exceptions, some of those that just presented today, these don't exist in most clinically integrated networks, okay? But ideally, these are the things you'd want to have active participation in every one of these building blocks. And if you're missing some of these building blocks, you're not going to be the Kaiser, or you're not going to be some of those that we think about day in, day out. But it still is useful to look at these building blocks as you're building your pyramid to understand where you need to be. Because I'm going to talk just a couple of minutes about this and talk about some of the more important pieces, at least from my perspective, and some areas where I think historically we've kind of missed the boat a little bit. And so obviously physician leadership is the single most important building block of this pyramid. And you've got to have engaged physicians who understand what needs to happen. And I think there's been a tendency in the past to not appreciate the importance of primary care. I think that is rapidly changing over the last few years, and I think appropriately so. And primary care has been seen mainly as where attribution occurs and where referrals come from, and a way to grow the network and grow volume. But it's not been really seen as that's where the patients get managed and that's where the cost containment and the quality improvements occur. So that is changing, and I think we need to emphasize that. The next layer up is after you get that physician engagement, you've got to have appropriate care models that are informed by data and analytics. And again, I built a large data and analytics company, but I'll tell you again that most places do not have adequate data and analytics. And most entrants into the market trying to get into value-based care typically will rely on their hospital systems for data, and they'll rely on payer reports. And those two things are okay for a beginner set, but they're not good enough to really get you to that next level. The expertise within hospital systems aren't focused on the kind of things we're going to talk about, and their analysts, their data scientists, et cetera, are a different breed than what we need from a value-based component standpoint. And then developing the delivery network. I will mention UpStream here. I think one of the differences in UpStream compared to some of the value-based companies is that we take all comers, okay? And so as opposed to trying to aggregate patients into a center, we partner with every primary care patient that sees Medicare patients. And our goal is to bring all of them up. Some of them have lots of Medicare patients, some of them have only a few, but we partner across the board and we treat them all the same. We isolate them in terms of their quality and outcomes. And so if you're in a given network and you have one practice across the street that's doing poorly, but the other one across the street is doing great, we incentivize the practice that's doing great. Okay, so as practices, and I'll talk about the model in a minute, as practices improve, they see that reward immediately as opposed to 18 months down the road. We'll talk about that. And then I think developing a financially sustainable model, in my personal opinion, I think this is where we've fallen down a lot too, because we are so timid to get into risk arrangements that we fail to recognize that if you don't have enough upside potential, you can't generate enough money to cover the expenses. And the secret to success in these models is data and it's expertise. And this kind of expertise doesn't come cheaply. And so you can't, somebody said to me, if you think expertise is expensive, wait till you hire inexperienced. So so you really got to go after those people that know how to do this work and invest a lot of money up front. But I'll show you that there is money out there. And I'm talking about private equity money. I'm talking about money from CMS that can cover these things. So next slide. So this is just a layout. You've all seen this slide, the continuum of care. And the only reason I put it up there is to point out a couple of things. Number one is you do have to think about and address the entire continuum of care. You're not going to be successful in Medicare if you don't have a great post-acute program, for example. So you've got to do that. But the other thing that this continuum of care slide represents to me, which is supposed to represent the continuum, what it also represents to me is the fragmentation. And so you can even see from this slide that there's multiple boxes, there's multiple entities within each box. They all have great initiatives going on, but even coming from integrated delivery systems, they're still fragmented. The fabric that we heard about before is the ideal thing that we're all striving for, but it's hard to obtain that fabric seamlessly across every aspect of the organization. The other thing that I would point out is that primary care in that left lower box has been, again, traditionally ignored as a site of where the actual care occurs. And when I say care, I don't mean the care from the physician, but the team, and we'll talk a little bit more about the team, creating a team focus there in that practice and creating what we refer to as linear integrity. And so that primary care practice with the right support systems and the right team can be that mini care management company that for its patients is driving that linear integrity across to the hospital, across to the post-acute systems, across to the community-based organizations, and driving very direct care in a relatively low technology standpoint other than risk stratification and data analytics. Next slide. So again, just re-emphasizing this is that changing how we think about primary care, it is the first contact that patients have. It's the first opportunity to do risk stratification. It's the first opportunity to intervene. I think primary care has been a missed opportunity in general to intervene. And go to the next slide and we'll talk a little bit more about that. So transforming primary care to really be, rather than being the old PCMH model, being a true primary care transformation model, okay? And that requires an embedded care team with multiple resources. And interestingly enough, the money is out there today to cover that. Most people don't utilize it. I think when we did our own study, we realized that chronic care management fees were only charged about 14% of the time. Okay, that's a huge missing opportunity for primary care docs. So if you add up the chronic care management opportunities, the transitional care management opportunities, the remote patient monitoring opportunities, the annual wellness visit opportunities, there's a significant amount of dollars there that can transform a primary care practice into a care management hub that can identify, risk stratify those patients, manage those patients through the primary care practice, and create great outcomes. Now, that team that is supported through those revenue flows needs to be very specific. And so it can't just be that you're hiring anybody, just another nurse to put in the practice. You've got to really think through what you're hiring. But again, that team, so we had a doctor present at APG meeting last week in San Diego, and he stood up and said, okay, I'm a primary care doctor, and I just saw a patient who had 5 chronic medical problems. They're on 12 medications. They had side effects from the medications. They had transportation problems. They had social determinant problems. Tell me how I'm supposed to strategically decide which one of those problems to address in a 15-minute visit. And the answer was you shouldn't have to prioritize any of those at all. And if you had a team around you, number one, that would have not occurred to begin with because they're cycling in the back, addressing those things before that patient gets in to see you. And when you see the patient, you already know what's going on with that patient and what's being done for them. The other thing that team can do is what our team does is before those visits. So we have every patient come in and see that care management team, which includes a clinical pharmacist. And they are specifically trained to do certain things. But that team will reach out and get medical records from every specialist that patient has seen. Because although it sounds reasonable that you would expect that those would get sent to you, they don't. That you could retrieve them electronically, you can't. My previous clinically integrated network had 83 different electronic medical records, okay? And you'd never got anything from the ophthalmologist. And so, so this team serves to aggregate all that data, bring the patient in. They'll spend as much as 90 minutes with the patient, going through all those reports, going through how they're doing, listening, trying to understand what the patient needs are, what their expectations are. And what we've seen is that once those patients come in and see that care management team, that there's almost 100% retention rate in that model. Is that they begin to recognize those ancillary support team members as their team members, and they become very attached to those. They're available to them 24/7. And we embed those in every primary care practice. And those patients will call that pharmacist or call that nurse care manager for any kind of problems they have. It takes a lot of workload off the primary care doc. They also handle all of the pre-auths from the pharmacies, from the insurance companies, et cetera. So the primary care doctors love it. And they work to close all the gaps in the practices. They bring those patients in and they look at where those gaps are. They schedule their mammographies, they schedule their colonoscopies, et cetera. Next slide. So it does have to be that right combination, though, and they do have to be trained. So you can't just get a pharmacist and stick them in there. So we put our pharmacists through something called UpStream University, and they're actually trained in motivational interviewing. They're trained to listen. They're trained to look for these very specific indicators of health outcomes and to document those and to address those issues, to address those social determinants. These embedded teams, although we say embedded, we have some that wrap around the practice too. And as you heard earlier, they go out to the laundromat and meet them, or they go to their home and meet them. And those are unlicensed but trained professionals that go out and do that. And so there's varying levels of expertise in that model. The other thing that we do that I think has been a differentiator, because one of my issues has been, even for my previous network, is that from a doctor standpoint, you're working all year long. You really have very little line of sight of how well you're doing. And then to the end of the year closes, and then you wait another 8 months and you cross your fingers and see if you're going to get any shared savings. And so after a while, that becomes a little demotivating, particularly if you go some years where you're not creating shared savings. So in an UpStream model, they're confident enough in their model that they know they're going to make shared savings. So they're actually paying the physicians up front. But we don't pay them for shared savings. We pay them for quality. And so we actually have a star rating system for quality based on all the typical metrics you would think of. And as their quality improves, then we pay them more. And so they get paid a certain PM for this level of quality, but as their star ratings go up, they can actually see their monthly income going up. And so it motivates them to participate in the team, to close those gaps, to drive quality. It's not about utilization. It's about driving quality. The team is addressing utilization by managing those referrals, managing the hospitalizations, managing the post-acute, but that encourages the doctors to work with that team. And so the docs see immediate reward. We're seeing great returns on the back end with this model. So we take all the downside risk and we guarantee the upside risk, and that clinical embedded team is what drives all the outcomes. And it's amazing that just a handful of embedded team members compared to a telephonic model drives dramatic improvements in quality and shared savings. Okay. Next slide. So again, you've heard a lot about data and analytics, and obviously it's important. Most people don't have access to the kind of data you've heard today. We had a fairly sophisticated data system at the previous organization I worked for, but even that was relatively unusual. And so, but you do need that. I mean, that is the ultimate goal, is to develop that level of data integrity and data abilities, because you got to aggregate. And again, it goes back to one of the problems is in our network, we had 83 different EMRs. And so developing the processes to get that data, to centralize it, to aggregate it, to scrub it, to normalize it, to match it with claims, to do all that is a huge undertaking. Then to use all that to risk stratify patients, both from a cost standpoint and a clinical quality risk standpoint. And we're now rebuilding that at UpStream, similar model. So that is a very difficult task and something that's very expensive. again, I think relying on hospitals is probably one of the disservices that most organizations do, because they're depending on that kind of data, and hospitals just aren't equipped to do the things that I just mentioned. So you really got to either build your own or reach out to a partner or some other data company to help bring that data to the table. If you do that, then I think many more primary care practices can get into the value-based arena than we've seen get into in the past. You know, the barriers have been that upfront expense. You know, it's just too expensive for primary care docs to get into the value-based arena. They don't have the capital to take downside risk. Even $5 billion organizations don't want to take that much downside risk because it hurts their bond rating. You know, they can afford to lose it, but it hurts their bond rating. And then the data and analytics. So those three things really are barriers. So next slide. So again, as I think through what the barriers have been that I've been exposed to that have really prevented us as a country from moving more rapidly into value-based care, has been, you know, a reliance on hospitals to help drive this. And again, it's not that they don't necessarily want to, it's just not their business model. They don't have enough patients in their system for it to become important for them to make the appropriate investments in that they need to do. Again, with notable exceptions. We all hear about the great organizations that are doing this well, but I'm talking about through rural Southeast United States, that just doesn't happen very often. Lack of the upfront investment, physicians don't receive real-time incentives, unable to take the downside risk, not enough volume. Those are the barriers. So next slide. And then my last slide was just really, so how do we get past this? I think developing enablement resources or partnering, and I think the good thing that I'm seeing in the market is that more of these companies are developing that can at least bring data to the table, you know, that's appropriate data that the practices and networks can use. And I think there's opportunity to make those upfront investments if we educate our practitioners. How do you bill chronic care management, transition care management, you know, educate them on the importance of the annual wellness visits, et cetera. All of that are huge drivers to success, and they pay for themselves if you learn how to manage those correctly. The real-time incentives is a problematic thing. There's not many companies that pay up front real time, but I think that's becoming more recognized as a need to do that. And then enough to embrace enough risk. And what I hear constantly in these conversations is we've got to move to downside risk. That's a little bit of a negative tone for me, because it's not that I want to go to, all of a sudden I want to start taking downside risk. What I want is I want lots of upside potential. And to do that, I've got to take some downside risk. And so, but you're never going to have the money to invest in the things you need to invest in unless you're willing to take that upside risk. And the odds are that you're not going to have to pay on the downside. Scale does matter. And so if you're managing 15,000 patients, your year-to-year variability is significant. But if you're scaled, you're managing 1 million patients, then that kind of evens out over the years, and you may have one network that does poorly, but another one that does well, and so your risk even out. And so I think, scaling across the country with various organizations is another important aspect of how we're going to spread this across the U.S. More quickly than we have in the past. So I think that was my last slide. So it's really open for questions.
I have one.
Go ahead, Bruce.
Oh, thanks. It's a two-part question, so wait for the second part, please. I guess you mentioned, I was thinking of volume. What's the minimum that you can get something going in the direction of value-based care in a given market? Is it based on the number of patients?
That's a great question. So we look at it in two ways. We look at it per practice, and we look at it per microgeography. So in a microgeography, we need 4,000 patients. And in a single individual practice, it doesn't make sense for us to embed pharmacists and care management staff if they have under 200 patients. And the way that we do that, so we use that 4,000 patients supports an entire team that includes a clinical pharmacist, a nurse care manager, and a concierge team of non-licensed people that surround those three individuals. And they cover 4,000 patients. And so if you've got two practices, each that have 2,000 patients apiece in them, then they're splitting half of their time between those practices. But they're available to those practices 24/7, and they're available to those patients 24/7. But when it gets down to where a single practice has under 200 patients, it's not very productive to have that model in place. But we do that sometimes because we may have a network that has 50,000 patients, and there's a few rural practices in there that have 200, and so in the bigger scheme of things, we provide that service anyway.
I'm going to jump in.
As I was listening to Dr. Khan and some of the statistics he cited, where it seems like they're in many markets, but the market penetration in any given one is pretty low, and even to the point of saying, well, there's no specialist organization that derives more than 10% of their income through their presence there. Would you pursue a strategy like that? It sounds like he's successful, but is that the exception rather than the rule?
Yeah, we actually take the opposite strategy in that and there are even a lot of delivery systems that are trying to move towards, senior clinics, that kind of model. And after talking to us, they're reversing their strategy and they're going to go with us because our strategy is to allow patients to see the practitioners they want to see. Don't take patients away from doctors who have long-standing relationships. Let's embed the resources. Let's give the doctors the time, the resources, the patients the resources, and we've proven that we can drive utilization down 45% a year over year, and create savings of 10% a year with this embedded model. And so ours is a much broader footprint, more scalable than trying to create individual practices.
I have a question for you about social determinants and addressing equity. So you have the perfect scenario. You're not only with one payer or one population. You've got everyone.
Yes.
So I'm curious, what have you found to be the most impactful investments for addressing health-related social needs? And then in relation to that, what partnerships or revenue shifting are you needing to build in order to meet the demand that you're finding as you're proactively addressing that with large populations?
From a social determinant standpoint?
Yeah.
No, you're right. Since, we do all of our contracts are global risk, and even on the fee-for-service side, either DCE model, now REACH going into this coming year, and MA global contracts. And what we're finding is, so I'll start from the top, huge educational opportunities. Patients come in and they don't know how to access the system. They're on multiple medications. They don't understand their medications. One of the things that we do is that we synchronize their prescriptions so that they're getting all the prescriptions filled on the same day of every month, because otherwise they're trying to get to the pharmacies multiple times a month and they miss them, because the number one driver has been transportation. They cannot get to their doctor's office. They can't get to the pharmacist. They can't, even if you refer them to a community-based organization, they can't get there to talk to them. And so transportation is the issue. And we have partnered with cab services, with EMS, with others to help drive those outcomes. That solves the vast majority of problems, because if you can transport them somewhere, you can get most of their issues taken care of. It's just the transportation. So,
Thank you. All right. I wasn't paying attention because I was so excited by my own question. Who was first?
We'll just say it was me. So, first of all, Angelo, I'm going to say fantastic and hip hip hooray. In a fit of convergent evolution, I had exactly the same experience in private practice in Kansas that came with the very same lessons learned, which was such modest investment in primary care of about half an FTE nurse care manager, one extra medical assistant per physician, one LPC per clinic site, and a tiny smidge of a clinical pharmacist. You can get what you need done, and you laid out the revenue sources that cover it. It makes perfect sense. Leads to two follow-up questions just to see what your experience was, parallel to my experience, which was first two parts. One, with your providers, the biggest sticking point is often just getting the time and attention of the individual docs to engage and trust their team to do the amazing stuff behind the scenes while they're in an exam room. And so what did you find to be the magic tipping point for your docs, doc by doc? And secondly was, we actually had more resistance in the management level of most of the clinics than the docs. Managers, of course, being trained to maintain homeostasis and keep the bus moving smoothly, as opposed to a leadership mindset of what's the potential for the future. And so we actually had some retraining at a management leadership level that made a huge difference. So if you can comment on those two aspects.
Yeah, no, I would agree with you. I think, and one of the ways that we train our staff is we tell them, so your primary responsibility is to the patient. Your second responsibility is to the doc in that clinic. And you're not there to disrupt his workflows. You're there to partner with him to help make his workflows more efficient. Even with that, to your point, it takes about 4 months before the doc begins to trust that these staff know what they're doing, that they're not there to disrupt his day and make his day. And it's interesting, as we're talking to potential new partners, that's always the number one thing that comes up is, what kind of abrasion am I going to get when you embed your team in my practice? And we're going, this is your team. We're training them, we're hiring them, but they're your team, and this is what they're going to do for you. And you've got to be willing to work with them to let them do that. But even with that, there's that tension and resistance. But typically after about 3 or 4 months, they're like, oh yeah. In fact, I had one of the, so this is a country doctor, you got to understand his language. So I had a doc call a primary care practice out in the rural area to describe this lack of abrasion that you're talking about. And he called me up afterwards, and he said, "Yeah, I talked to Dr. Such and Such," and he said, "I'm glad my office staff wasn't in the room." I went, "Uh-oh, what did he say?" He said, "If my office staff had been in the room, they would have wrestled me to the ground and put a chokehold on me until I signed the contract with you, because they took so much of the administrative burden off the staff." And that's what gets the staff bought in, that all of a sudden now they're freed up to spend time with the patients too, and they're not answering all these pharmacy calls and all these other things. And so, but it takes a number of months for them to kind of recognize that's what's happening. So, good question. Thank you.
Jay.
Angelo, does your company hire the team for the doctor's office?
We do. We do.
Do they have any input into those decisions?
Yes, they have hiring and firing rights. We train the teams. We bring the teams to them, but they get to meet them, make sure they're a fit culturally. And if at any time during the course of their employment there, they get sideways with the docs can fire them, and we have to bring in another team. But they do participate.
And are they on the physician's payroll, or are they on your payroll?
They're on our payroll.
And is it part of the package?
Part of the package. And so we cover all the costs for all the teams, as well as paying the docs that monthly PMPM.
And when you say embedded, do you mean face-to-face action, or just it's owned by the physician practice? So if they have to do telephonic, it's still part of the practice, or it's just has to be face-to-face? I'm very curious about that.
So we have both of those. So we have actual physical bodies in the office. We have a clinical pharmacist and a nurse care manager actually in the practice. And they may not both be there the same day. You know, the scenario I gave you where they might be covering two practices, one may be in one and one in the other, but somebody's there most every day. And they're interacting with the docs. They've got a space where they can see the patients. They do the intake, so to speak, of those patients and meet with them and manage them. We also have we do have some telephonic care management services. We found that they're really only useful for follow-up issues. We don't like to use them as a primary resource for care management. It's if somebody just needs to be checked on to see if something happened or if they got their prescription, then we can call them, and we can call them from a central office. But we want them to have that relationship with that pharmacist and that nurse care manager, that they feel like that's my pharmacist and my nurse care manager. So. We also, you know, those that we are seeing so intently, it averages to be about 30% of the entire Medicare population. Those are the ones that we're really seeing in the office and intently. That other 70, we have a team that's outside the office that's following up on those, because what you heard from somebody earlier today, that 70% is actually what drives a lot of the gaps in care. Because we're paying attention to those top 30% and trying to fill those gaps. Those 70%, those rising risk and those, quote, you know, well patients, that they aren't getting their colonoscopies done, but they're not sick and they're not utilizing yet. And so we've got another team that addresses those and makes sure that those gaps are being filled.
Thanks.
Jennifer.
Thank you for describing your organization and your previous experience. I think there's a lot of themes that we continue to hear, not only today, but in our other sessions. So it strikes me that in fee-for-service, a balancing measure that was created out of that system is utilization management, right, to restrict access. And yet we had a number of speakers, including yourself today, talking about number of touches being a process measure to validate interactions, which improve outcomes. So we heard today about a ratio of a PCP to specialist consultant, and one of our speakers said a one-to-one ratio was where they were focusing. And then if I took notes appropriately, Dr. Zimmerman said that the goal was to have 95% of patients being seen once per week, which right, is obviously really high. So again, you just described high touch and also 24/7 access. So can you talk a little bit about how to operationalize that, especially as we're thinking about workforce issues and folks who are, you know, leaving the specialty because of, you know, emotional stress, and yet this is creating potentially an unintended consequence of unfettered access of patients to resources. Are you finding it difficult to find staff who want to have 24/7 accessibility to patients, number one, and then number two, what are the metrics that you're following around validating that there's a high touch?
So we've not found it difficult to recruit staff. So there's an abundance of pharmacists out there right now, and a lot of new graduates who are having difficulty finding jobs. And then because of this model, a lot of the pharmacists are tired of counting to 30 every day. And so they are looking for these kind of jobs. And so, and we pay very well. And so for every open spot we have, we typically have at least 5 great applicants for, and we have to decide between those 5 which ones to put in a practice. So nurses are a little bit harder to find, but this is such a unique job, again, that we've not had problems so far finding enough good nurses, but just because of the nature of the work. It's what they went to nursing school for, you know, and so we've not. And they've loved the interactions. They've loved being available. And they don't really get that many calls at night. You know, they are available 24/7, but if they're doing their job, those things are taken care of during the day, and there's not many nighttime calls. And so, and we are measuring touches. We measure how much time each of our staff spends with patients. They average about 7.5 hours per year. actually, directly conversing or meeting with the patients. It doesn't sound like a lot, but that's actually a lot of time compared to nothing. And that intense and structured time with them is really what's driving the outcomes. And so we do measure that, and we measure patient experience and get feedback from patients about it too. So,
Walter. I mean, Larry. Yeah, you can tell them
Angelo, I have to tell you, I can't tell you how much I enjoyed listening to you and how much I relate to the environment you're building, because it's so similar to what we're doing. Touches are such an important concept. They supersede the difference between PCPs and SCPs. Because really what you're doing, what you're calling primary care, is proactive engagement with patients. And we call it touches because it can be in multiple different fashions. But a specialist managing a condition that has a very high ratio of disease-specific cost to total cost, those touches are equally as important. And I think we heard that in the renal disease piece earlier today. So one of the things we've done with touches is I hate the word automate, but I'm going to use it, but we automated them. They are part of the technology platform. Mm-hmm. And we're in an environment today with patients where patients want to engage in the way they want to engage, and we have to adapt to that. We can't retrofit it. Right. I know we heard a story about trying to find a gray Celica, to get a diabetic. That's obviously the extreme, but, you have to figure out a way of engaging with those patients so you can proactively avoid the deleterious effects that happen with poor engagement. You're right. We found out that 200 patients was the minimum. But on the other side, that nurse care manager doesn't have to be a nurse, but that care manager can handle a lot more than the 200. So you build a lot more efficiencies as you bring in more patients. And we really don't have an upper end to that established yet, because there is a lot of elasticity there in how many patients you can encounter there. So you're doing great things, and I think there's a science. We've heard some things today that have permeated multiple presentations, and to me, what I'm coming away with is that engagement is so critical, because we heard that in just about every successful story up there. And whether that engagement is being done by a PCP, an underappreciated PCP, I should say, or a specialist, I think we have to get to the patients before the patients realize that they need to be encountered.
Thank you.
I think.
Oh, one more point. Okay. I forgot.
Only one.
My team, I emailed my team because you mentioned CCM and PCM codes. One of the things that's a problem today, these are not first dollar codes. A patient gets a deductible every time we use them. So if they're realizing that we're doing something for them, they can accept the fact that they have a hit to their deductible and their copay. But if we're using it proactively and maybe they don't realize they're getting that much benefit, it would really accelerate the use of these if they were first dollar. And there's a bill in the House.
So if I can make a comment about that, is that, so when we reach out to patients, we always describe that to them so they're aware of that. We only get about a 70% uptake because they're worried about their copay. Of the 70% who decide to take it, and sometimes their copay is covered by their supplemental or whatever, that's where we have the less than 1% attrition rate. But as we move into REACH actually has a waiver, so that as long as you do it for everybody, you can waive the copays for these chronic care management fees. And so that's our intent, is just to waive the waiver, because it's so valuable to get those patients in.
It's a fantastic presentation, Angelo. It's really great to see weaving together the themes and the depth of knowledge and experience from having done this and best practices. So we've heard some fantastic themes today, really great dialogue and discussion. And now we're going to turn it over to Victoria, an analyst with ASPE, to update us on the request for information and input that we issued in March. Victoria, please go ahead.
Hello. Excellent. Thank you so much. So I'm here to give a quick plug that PTAC has released a request for input, or RFI. The RFI is an important part of the committee's work on population-based total cost of care models, and the RFI is still open. So members of the public are asked to submit by July 20th for the committee's consideration as part of this series. And as a quick disclaimer, I'm not speaking on behalf of PTAC right now, and I'm also not endorsing specific comments or policy positions. So if we could go to the next slide, please. Excellent. So throughout the committee's history, at least 10 of the physician-focused payment models that stakeholders have proposed discuss the use of total cost of care measures or other related elements, which led the committee to plan and hold this theme-based discussion series. The purpose of the RFI is to gain additional stakeholder insights that can then inform the committee's review of proposals, as well as recommendations provided to the secretary. I think the chair noted this morning that the committee is going to draft and release a report to the secretary of HHS on this topic after the series concludes in September. So this RFI is a great source of stakeholder input to lead to those recommendations. So if we could go to the next slide, please. Great. So 7 different organizations have responded so far, and I'll leave this up for a moment so that our audience can get a sense of who has submitted. These public comments that have been received so far are available on the ASPE website. And as you can see, we've heard from a few different parts of the healthcare system. Next slide, please. Great, so here are some of the topics that the committee asked about in the RFI. I do want to share some brief highlights of what has come in so far, but note that this is not a comprehensive look at the responses, and I think a lot of these will sound familiar based on what you have all been hearing throughout the day. So I'll note that for defining total cost of care, there has been a variety of ideas about which services should be included when calculating total cost of care. In terms of the design and implementation of these models, several respondents suggested incorporating a wide array of providers and entities that can potentially contribute to reducing total cost of care. That was also a care delivery best practice that people wrote in about. Some respondents also said that using clinical workflows and data analytics can help facilitate innovative care delivery. In terms of accountability, respondents tended to favor setting accountability for total cost of care at the entity level rather than at the individual provider level. And for provider participation, stakeholders who responded shared that being able to manage total cost of care does vary by many factors, such as specialty, data availability, providers' history of prior participation with value-based care arrangements, patients' health status, and so on. Respondents said that to improve coordination between primary and specialty care providers, there are several factors that tend to be important, including access to timely and accurate data, expanding payment opportunities to all necessary services in real time, as well as expanding regulatory flexibility when possible. And for that last category, I'll note that some respondents wrote in that while incorporating and embedding episode-based payment models into or within a population-based total cost of care model can be useful, this requires a very clear definition of the episode, as well as transparent rules about the accountability. Great. And next slide, please. Great, so that was just a sample, and the full RFI and stakeholder responses are available online, and members of the public are welcome to submit by July 20th for the committee's consideration as part of the series. Thank you. Back to you, Lauren.
Thank you so much, Victoria. At this time, we're going to take a short break. PTAC public meeting will resume at 3:30 with committee discussion about themes and things noted from today. So from 3:15 to 3:30, we'll take a break. Thank you all so much for joining.
Produced by the U.S. Department of Health and Human Services.